Hi, my name is Atif Darus, professor and consultant of obstetrics and gynecology. You know that July is the Fibroid Awareness Month. And by this event, I would like to share you an important topic, which is not uncommonly seen in our practice, which is calcified fibroid. What are the therapeutic challenges and are they important? Are they treated like any other fibroid or not? You know, a calcified fibroid is an untreated fibroid that has been mineralized with calcium deposits. And these calcium deposits make it hard, but to be similar to a stone. Actually, it is not commonly seen, but it can be seen in our practice. And in this old publication, the incidence was 5 every 4,000 abdominal X-ray examinations. And all of us know that calcification is a characteristic of a postmenopausal fibroid, but we don't have to think that all calcified fibroids are occurring in the postmenopausal age, because we can see calcified fibroid in a young patient, 20s, 30s. What is the cause of calcification in this young age? The cause is, in some cases, the growth of the fibroid is too rapid that outweigh the blood supply. So the blood supply is insufficient to this growing fibroid, and this will lead to decreased nutrients and oxygen, and subsequently degeneration will occur. We know that there are different types of degeneration, but hyaline degeneration is observed in up to 60% of cases, and in up to 5% of cases, there are some cystic degenerations and calcification. So calcification is a sequelae of the rapid growth of fibroid that is supplied with insufficient blood supply in some cases. Another explanation is an iatrogenic intervention, where interventional radiology use uterine fibroid embolization to stop bleeding in asymptomatic fibroid. This makes the same mechanism, decrease blood supply, degeneration, and calcification subsequently. But we know that postmenopausal calcification is the commonest, because in postmenopausal, the same mechanism, decrease estrogen, decrease blood supply, decrease growth, decrease volume of the fibroid and ischemia, and this leads to degeneration and shrinkage in up to 90% of cases, but in rare or very rare few cases, calcification occurs. So we should put in mind that fibroids usually calcify at the end of their life cycle, and this typically occurs after menopause. Here is an example of uterine fibroid embolization that in most cases, the myoma become degenerated with hyaline type necrosis, and about 5% undergoing cystic degeneration and calcification due to aggregation of the polyvinyl alcohol particles in the peripheral fibroid arteries. We have to know that calcification is commonly seen in the periphery of the fibroid. And here is another example of the causes of calcification. In some cases who were exposed to brachytherapy and had fibroids, after the brachytherapy, the fibroids appeared as calcified. Some parasitic fibroids, which are type 5 according to FIGO classification, became calcified, and this can be explained by poor blood supply, the same mechanism of seeing fibroid in any reproductive age patient. Diet is not a cause of calcified fibroid. Calcium, excessive calcium is not a cause. There is no relationship between calcium deposition in the soft tissues and the calcium intake. But sometimes in postmenopausal women, the myoma starts to grow more and more, not to shrink, as already mentioned. And we have to explain this to the patients, and we have to put this in mind that the main issue of concern is sarcomatous degeneration, and we should put in mind this. rapid growth of fibroid in postmenopausal women. But sometimes if the patient is obese, he has an extra ovarian source of estrogen that leads to growth of the fibroid, or some patients have increased growth factors, and these will lead to increased DNA synthesis or proliferation of smooth muscle cells and promote angiogenesis and mitogenesis. And this restores the growth even in cases of decreased estrogen. And by the way, the mechanism or the theory of increased growth factors is based of some new approaches for treating fibroids nowadays. What are the symptoms if we find a patient with calcified fibroid? Usually, the patient is asymptomatic and discovered this accidentally during ultrasound or X-ray. But in some cases, she may have a pain symptom like dysmenorrhea, dyspareunia, back pain, low abdominal pain, some problems if it compresses bladder, frequent urination, incontinence, if it compresses colon or intestine, distension, incontinence, bloating, or abnormal uterine bleeding if it is nearby the endometrial cavity. Sometimes the patient comes with hematuria, pelvic pain, and this due to this calcified fibroid and the mechanisms that this bony tissue starts to make irritation and ischemia of the bladder wall, and this may lead to fistula later on, as in this case that has been treated by hysterectomy due to this calcified fibroid. And it has been reported 7 cases of vascular fistula with calcified fibroid, 4 of them after uterine fibroid embolization, and the mechanism, as I told you, inflammation and necrosis, or new vascularization after ischemia of this fibroid. So this fibroid can be invasive, but not like malignant invasion, because it is hard and some sharp edges of this fibroid can penetrate the wall of the uterus and the adjacent tissues like bladder. And in this case report, the bladder has been invaded and partial cystectomy was done to treat atrophy and erosion of the posterior wall of the bladder. So the diagnosis is commonly during examination, you can see it. You can see peripheral calcification, and if the myoma is big, it looks like fetal head. If not, you don't forget this view of peripheral calcification. But sometimes calcification is the whole fibroid, not only peripheral, because the blood supply may be disturbed or distorted, so the whole fibroid can be calcified in some cases, and also during routine X-ray for any cause, this view can be seen. And there is a case report of what's called popcorn appearance on X-ray due to homogeneous calcification of the whole fibroid, not peripheral calcification. Now we come to the topic of this lecture, which is treatment plan. How to do for a patient who is calcified fibroid. The first question, is it symptomatic or not? If not, we don't have to interfere, okay? Inform her that she has a calcified fibroid with excessive calcium deposition and no symptoms, no treatment. And if the patient is symptomatizing by abnormal bleeding, pain, or whatever, we have to interfere. Interference by non-surgical procedures like medical treatment or uterine fibroid embolization or a high or ultrasound radiation or interventional ultrasound. But surgical procedures like myomectomy or hysterectomy can be endoscopic or conventional, and these endoscopic procedures can be laparoscopic, hysteroscopic, or robotic. Regarding medical treatment, we can start by selective progesterone receptor modulators that may lead to shrinkage of the fibroid, controlling bleeding, improve anemia, like olipristal acetate. And these are the advantages of selective progesterone receptor modulators. But the main drawbacks of this line of therapy include abnormal endometrial change and liver impairment. That's why in 2020, the European Medicine Agency mandated that this olipristal acetate is only indicated for patients who cannot undergo uterine fibroid embolization or myomectomy. Another hormonal treatment, which is GnRH agonist to decrease heavy menses, decrease volume of the fibroid, and this is commonly used in practice for at least 3 months to achieve these effects. But complete cessation of steroid hormone production by the GnRH agonist associated with life-altering side effects, including climacteric symptoms of hot flashes, bone mineral density loss, and subsequently osteopenia or osteoporosis are the main drawbacks of the GnRH agonist. Some studies used levonorgestrel IUD, which is considered as a first-line treatment of heavy menses, but it is off-label. It is not recognized by the organizations or societies as a line of therapy so far. A new approach for treating these symptomatizing fibroid, including oral non-peptide GnRH antagonists, and they achieve rapid onset action and dose-dependent effect without full suppression of estrogen. And this is actually a good achievement with encouraging results and high safety profile. However, elagolix and rilugolix are combined with decreased estrogen. So they have to be associated with add-back therapy to minimize hypoestrogenic side effects such as hot flashes or flashes and bone loss. There is a novel type of GnRH antagonist, which is linzagolix, which is only GnRH antagonist developed for fibroid-related heavy menses without add-back estrogen and progesterone, can be used in 100 or 200 milligram dose daily. Now, what about the high-frequency or high-intensity focused ultrasound? This can be done ultrasound-guided or MRI-guided to achieve devascularization of the fibroid. And the studies found that ultrasound-guided high-intensity focused ultrasound devascularization is more efficient than MRI. However, this is the first caution of this lecture. However, we don't have to advise our patients to do the HIFU because peripheral calcification is commonly seen in these fibroids, and this is a relative contraindication due to reflection of the ultrasound beam. So if you have a patient who is calcified ultrasound, don't advise her to do this line of therapy. Another caution of the treatment of calcified fibroid is not to offer your patient hysteroscopic resection using the loop of the resectoscope, because the loop of the resectoscope will try to cut the fibroid. It is like a bone, like a stone. How to cut a stone by the electric current? It will not work. It will not work. So don't waste your time and cut this stone by these loops. You will lose a lot of loops, and your budget of the patient will be too much because of the several loops cut by the resectoscope. And here is an interesting case report of 35-year-old infertile woman with menorrhagia that has been subjected to hysteroscopic resection by the resectoscope. And they broke in 5 loops, and then they couldn't excise the whole myoma. So they used orthopedic forceps to cut the myoma, and they achieved the total amount of the weight of the myoma excised from the uterus was 51 grams. And insertion with orthopedic forceps was done after forcible dilatation of the cervix. But the patient continued to have bleeding and fibroid, so she was subjected to another trial of hysteroscopic resection. And in this trial, they used pneumatic urologic litho trial for cutting this myoma as if it is a stone in the bladder. They succeeded to get only 14 grams of myoma, but still the patient continued to have bleeding, and she went to another hospital who performed abdominal myomectomy for her. So they concluded that hysteroscopic surgery using this approach of resectoscopic excision is not suitable for this myomata. We introduced before many years a new technique, which is modified mechanical myomectomy. I advise you to use this technique for calcified submucous myoma, not to cut the myoma itself. Try to make circumferential incision around the base of the myoma by the loop, and you have to bend the loop to be 135 degrees to go to the base of the myoma and start to separate it from the wall of the uterus, and go to the pseudocapsule and make blunt dissection and separate the whole myoma from the uterus. By this way, you don't use currents for the calcified myoma. You go to the base of the myoma only, and this can be achieved after using misoprostol and or laminaria tint for softening and dilatation of the cervix. After this complete excision of the base of the myoma, you can introduce a ring forceps to extract this myoma via the primate cervical canal, as published by our team before. But I have a patient with calcified myoma for laparoscopic myomectomy. It's not submucous. Can I use laparoscopy? Okay, you can excise it by laparoscopy, but how to remove it from the abdomen? This is another problem. I advise you not to use the morcellation, because with either mechanical or power morcellation, closed or in the endobag or open will not be efficient. And the techniques with the advantages and disadvantages are shown in this lecture in the same channel. Why? Because the same idea that motor or mechanical cannot cut bones. And here is an example of one case report who excised a myoma in a postmenopausal woman, in a parasitic myoma, in a postmenopausal women by using endobag, but they didn't tell us how they could cut this bony tissue by the endobag. So some patients who are old age or completed their family may require hysterectomy. Okay, we will do hysterectomy with a patient with a uterus of calcification and calcified myoma. How to remove this uterus? We can extract it vaginally, but the bones may be entrapped during vaginal extraction. And this case report used number 11 scalpel to cut this calcified myoma, and used orthopedic forceps also to cut this bony or hard myoma via the vagina. If you try laparoscopic morcellation like this case, you have to rely on orthopedic instruments during the procedure, and you have to make small incision and try to cut it by this orthopedic instrument. And here is another case report using orthopedic instruments to cut the calcified myoma during total laparoscopic hysterectomy. Because the problem of calcified myoma is like a stone, how to cut it and to remove it from the laparoscopic holes. And this patient who was treated by robotic total laparoscopic hysterectomy, also they used laparoscopy to cut this myoma and extract it outside. If you cannot do endoscopic approach for such a case, the last choice is conventional hysterectomy of these calcified myomata. So in conclusion, we have to know that calcified myoma is usually asymptomatic, but symptomatic myomata should be treated. And the therapeutic approaches for symptomatic calcified myomata represent a real challenge. Don't forget to avoid three items, which are high intensity ultrasound, interventional ultrasound, HIFU, and you have to avoid loop excision by hysteroscope. You have to use modified mechanical hysteroscopic myomectomy. You have to use to avoid laparoscopic morcellation, and you have to consider orthopedic instruments for cutting of this myoma. Thank you.